already turn on the camera. Thank you. Yes, Professor Anand Krishnan is a medical doctor and epidemiologist. He has worked with WHO Southeast Asia for over a decade on NCD surveillance and prevention, and he currently leads the Minerva Network for Coding Causes of Death under India's SRS initiative. His team also provides technical support for the verbal autopsy component on the SRS India, and he will be focusing now on the presentation a bit on those on the verbal autopsy rollout within the pre-SRS implementation. Thank you, Professor Krishnan, and over to you.
Thank you. Shall I share the slide from my side?
Yes, please.
Thank you, Patricia. Hope all of you can see my slides.
Yes, we can. Perfect.
Okay. So I start with a disclaimer that I do not represent the sample registration system in India because that is run by Department of Home Affairs. I am a medical doctor working with a medical college in India, but I work with SRS, not in SRS. So I will be describing the SRS process, but this is more from secondary sources than from a primary knowledge. But the verbal autopsy part, I do that part, so that I'm fully familiar with, and I can answer any questions related to that. Okay, so one thing to understand is that right when India got independence, which is in 47, at that time, the whole thinking in all of these countries was a planning economy. And the importance of statistics was extremely appreciated by the people at the highest level. So India invested heavily on setting up many of these statistical systems right at the time of independence. So SRS, India is the first country to have started an SRS system globally in 64, 65. So you can see we are about 60 years since it has been started. In a pilot phase, and then in about 5 years, they ran a full-scale national. It is fully funded by the government, and there is a whole, as a part of Indian Administrative Services, there is a group of people who are Indian Statistical Services officers. They are the one who go for that part of the administration. And it is also the largest SRS system in the world. You can see it covers about 8 million population, which could be bigger than perhaps many countries of this world. But still, it is only 0.6% of the total population of India. So that is the challenge. And when we started, the cause of death was not part of it, but only in 1999, 30 years after it was started, that we included the verbal autopsy or cause of death component to an existing platform of SRS. So why did we start SRS? Because as you all are doing for the same reason, our field registration was not complete. And we didn't think that it would actually be, in near future, it would be reaching some sort of a completion. And since we needed reliable data for planning, and our CRS or civil registration system, even though legally mandated, our birth and death laws are also at the same time, 1960s. But they were not really fully implemented. So we decided that we will go for a sub-national data. And the SRS was designed to provide data at the state level for urban areas and natural division for rural areas, enabling targeted planning and interventions. And I will describe the process of the SRS shortly. It is a continuous data collection, and in the next slide, I will describe how it is done. So even though SRS also produces state level data for things like IMR, which is it is okay. It provides subnational data or state level data for birth rate and death rates, especially for the larger states. But it is now that IMRs have gone down, it is not really adequate for IMRs in many states of India. So that is a challenge that all of us have to keep in mind. What is an adequate sample size that when you start may not remain adequate over a period of time, though India keeps increasing its sample size. And I will come to that later. So the sampling frame, as you can see, is divided into rural and urban. And it is simple random sampling without replacement. And largely we look at in rural villages with less than, depending on the strata, we have 3 strata there. And similarly, in the urban, we have 4 strata, including 4th one being in metro cities. So it is and each of them you have a separate simple random sampling. And after every census, this is revisited because many rural areas would become urban areas. So this would keep shifting the rural urban based on the census that is held, which is held every 10 years. So as I said, this is about the sample size. The sample size was largely for crude birth rate and infant mortality rate at that time, which was in hundreds. It was more than 100 per 1,000 live births. Today it is around 30 live births, so almost a 4-fold decrease. And therefore, the unit at which you can use SRS estimates is becoming a problem. So this is how you see this thing has changed. After our usually census are held in every 51, 1961, 71, 81. And so after 4 or 5 years, the SRS units are revisited and their sample size increased. Currently, as you can see, we are following 2014 because 2021 census was not held. It is going to be held in 2026. Next year, it has been planned to held. So we are still working with 2014 previous census. And as you can see, we have about around 9,000 sample units, and each unit has about 1,000 population. So that's what comes to about 8.8 million or 9 million is the sample size. 5.6 in urban and about 2 in rural. 5.6 in rural and about 2 in urban. And initially, we were not giving 95% confidence interval, but in recent past, we have started issuing confidence intervals as far as for birth death estimates. So this is how the process of enumeration occurs. So we have a 2-step process, or we call this double counting. The first counting occurs by continuous enumeration by part-time enumerators. So part-time enumerators are not full-time employees. They could be school teachers or what we call as community volunteers who are already linked with some of programming government programs, already existing government programs. So they are the one who are the first rung enumerators. So they work with about 1,000 population, and they prepare a house list, look at household schedule, and they also look at list of pregnant women so that they are followed up for birth. So this continuous enumeration is done on a regular basis, where they keep noting the births and deaths and migrations and everything. In addition to this, the second step is a retrospective survey by supervisors. Supervisors are full-time regular staff of the Office of Registrar General of India. They again go to the same house every 6 months and find out what has happened to births and deaths and migration. Then they match these two. So these two occur independently. Then they match these two and identify discrepancies which are revisited and confirmed and reconciled to a final list. And that is used to generate a finalized list of births, list of deaths, and half-yearly populations for that. So that is the process that is being done. So 2-step process, one by community volunteers, second by full-time supervisors. And then they use statistical procedures, which I'm not going to detail, of converting this data into generating of rates through by appropriate weighting for stratum and other things. And every year it releases a report, generally about the next year of the concern. So 23 report is released on 24 and those of things. So as you can see, for 23, the actual survey takes till December, and then the reconciliation and report. And so in the second half of the next year is the report comes out. And it provides all the necessary information by specific age groups, including fertility, mortality indicators, and also access to medical care or medical attention at birth and death. this is what the annual report looks like. So it has a SRS bulletin which comes every year and which provides the details. As you can see, the graphs on the right side, it shows the decline over this period of time. And sorry. Yeah. And you can say in the death rate, there is clearly an increase in 2021 due to COVID. So this is the kind of report that is generated. It also relates SRS-based life tables. And bulletin on maternal mortality comes separately because there is a focus on maternal mortality. And later on, now they also release cause of death statistics, which is for 3 years together. There have been multiple evaluations of SRS. There have been, you can look at multiple publications of looking at SRS versus NFHS data, which is NFHS is India's DHS. And there are always some issues whether SRS overestimates, underestimates. Obviously, NFHS also underestimates. So this kind of studies are continuously done by demographers, which is good in the sense that it helps us understand how well is the SRS system working. Because even now, SRS is the most important source of fertility, mortality indicators, and cause of death in India. And therefore, it is important that this is regularly evaluated, and that could definitely be one of the lessons that one could carry. That plan evaluations of these using alternate sources of method and see how well this compares. So obviously, we take SRS as a sort of a gold standard or a reference method. Others will always come out to be not as good, but it is important to look at a much intensive inquiry. For example, you can see in a 10% subsample, a external group of people did a complete re-survey and then see whether it matched with SRS. And it generally SRS comes out quite well. So one can say that SRS has withstood time and different evaluations, and its quality is assured. So this is a continuous process. Reports released every year. There are internal measures for removal of duplications. The multiple evaluations have been done, and sampling frame changes every 10 years to give a wider representation of population and overcoming previous limitations. And as I said, as the time goes, the state level indicators, and it is not appropriate for district, which is our usual planning unit, but it can be used for state, at least for bigger, for birth rate, death rates. But sample of population is less. So that is about SRS, and now I'll move to the verbal autopsy part of it. So again, like we had two problems on the death front. One is that obviously deaths were not getting registered when we started, but the other more important was they were not getting medically certified. Less than 25% of deaths in India are medically certified. They occur in an institution. The rest of them occur in homes, especially in rural areas and for women. So therefore, till before 1999, there were no really good cause of death. It was only related to the medical certification of cause of death. We did not have a nationally representative data on cause of death. Therefore, it was decided to introduce verbal autopsy. So all the deaths that are identified in the SRS, we now have a verbal autopsy. Initially, this was also known as Million Death Study, and it was run by Center for Global Health Research. This is now being run by me and my institution. I lead this initiative for the Government of India. For those who don't know, AIIMS is the most premium medical college in India, institution in India. It is like Harvard of United States for Indian audience. So after initial pilot testing, looking at the forms, and then it was actually rolled out in 2001. And we capture around 45 to 50,000 deaths per year in the SRS. And as I said, initially it was by CGHR, and now we call it ourselves Minerva, Mortality in India Established Through Verbal Autopsies. And we have started coding from 2015. So for last 10 years, we have been coding the cause of death. So a brief about Minerva. And before that, so one of the challenges, and this was alluded to by my previous presenter, is what tool should be used. In 1999, when SRS was done, they decided to use a much shorter tool. This is perhaps the shortest tool being used as a verbal autopsy globally, with very limited, with the narrative, which is in the text portion, and very limited set of questions. And that continues to be a challenge. Initially, it was all paper-based, and it was made into an OCR form. These used to be scanned, and that was used for physician coding. So this continues to be challenged. This is the form which is even currently used. And this is not really amenable to CCV or computer-coded verbal autopsy. So I'm not going to detail of verbal autopsy and how it is done. So when we took over, we decided we would like to improve time. It was not very timely. And we look at quality and we look at use of the data. And to do that, we formed our technical advisory group. We looked at the team within AIIMS, which is the ATSU. We developed an IT platform for physician coding. And we looked at network institutions, because in India we have the narrative which is used in the form, and narrative we feel is, at least in the form that we are using, since it has very few closed-ended questions. Narrative is important. A narrative occurs in 16 to 18 languages. So we needed to have physicians to be able to multiple languages. So we need coders, physician coders in multiple languages. So we picked up our partners from every state in India to ensure linguistic diversity. And we developed an IT platform which could allocate physicians, the coders in batches, and then. So so one of the things that, since we are doing physician coding, and unlike the one that the previous speakers, we have about 500 to 600 physician coders empaneled with us, and our each form is coded by 2 independent physicians, and if they disagree, it goes to a third physician. And if he is also not able to do it, it goes for an adjudication by senior physicians. So that is the system that we are currently following in SRS. It is physician coding, not computer coding. So we do the training of people who do the verbal autopsy every year. About 800 supervisors we train every year. We do field visits for quality control of these verbal autopsies. We have multilingual physician coders, and we code about 50,000 deaths in a year, and then prepare all the analysis and send it to Office of Registrar General of India, who releases the report. So this is what we have been working on a regular basis. Now we are perfectly, we have almost finished coding 2024 forms. So this is occurring within a year. So this is now been very timely. We have looked at quality. I am not going to present details on that, but we have also improved quality. We have improved timeliness. Data use continues to be a challenge, largely because the data use occurs from health system, and unfortunately, right from initial design, health system has been excluded from the SRS. It is almost in a different ministry, and there are issues of challenges of data sharing and those kind of things. Except report, other things are not available for the program. So as I said, we have improved training by looking at quality. We have improved slightly. We have fiddled with VA tools to improve adult questions, but we were not allowed flexibility to change it in a big way. And we have also now introduced all verbal autopsies done by digitally. So we have reduced time which used to take from physical paper-based VA to scanning and to sending. Now it occurs on a real-time basis. You finish your VA, you can upload it to this thing, and it can almost immediately go to a physician for coding. So we have used digital tools to decrease timeline. Size continues to be 45 to 50,000 deaths. We feel is not that big enough in a. So when this is also going to be useful for the other countries to see how big is your sample size to look at cause-specific mortality fractions. While your sample sizes are all derived by birth rate, death rates, ultimately from usefulness, you will have to look at how much does the, for example, IMR. Today, our data out of this only neonatal mortality is a challenge in India. And we have about, in this sample, about 1,500 samples are of neonates. Is that good enough? It might be good enough at national level. But once you start going status specific, it leads to a lot of trouble. So while we don't really think about it when we are designing SRS-VA in sample size, India has a specific issue of languages, so it might be true for some African countries as well. And we did discuss on the uses. Okay. So one thing which has happened, and this is important, India's death registration and birth registration have drastically increased in this. Today, our registration of both is 90% and above. And therefore, the initial purpose of SRS is no longer true. However, our cause of death is still very bad. As I said, we only cover the MCCD, medical certified case, 25%. So if we crack this issue of getting, having a cause of death of all deaths which occur outside the hospital through doing verbal autopsies through the health system, not through the SRS system, we would also crack the other problem, which is then we don't actually require SRS. Currently, my team's focus is on focusing on how do we get verbal autopsies done through health system. And we are sure that for that, we will have to use probably CCVA, because we are talking about here 8 million deaths across India, 8 to 9 million deaths. So that's real physician coding in the way I said is not going to be possible. We'll have to look at some either hybrid model or a CCVA model. So current research of my team focuses on this half of this. We also strengthen MCCD, but our main focus is on covering deaths outside hospitals. And if we crack this code, India should start thinking of closing its SRS unit. So while till it runs, we strengthen it. We look at long term of establishing a VA-based system to cover non-institutional debt, employ digital solutions, and we look for more on integration of data and use of data. So that's the way that we are now looking at. So key lessons, this is my last slide. Plan long term, look at sample size from different aspects, and as I said, arrange resources internally. Set up a national technical advisory group, whichever form it takes, or an academic institutional collaboration, so that they can do some external validations, pilot testing of new techniques. So keep innovating. While the main platform does routine things, have an alternative way to test innovations. Include cause of death, and I was happy to see in Mozambique this was included, and I think today every country should include. Adapt digital solutions to the extent possible. Strong linkage to data users. As I said, we are not doing that good a job of it, but it is something that should be invested right at the beginning. And finally, as I said, do not decrease your efforts for universal registration. Remember, sample registration is a short-term measure, not a long-term measure. Thank you. I'm happy to answer questions.
Yes, thank you very much, Professor Krishnan. It was very insightful as well. I think we can open the floor for questions. Now we have about 10 minutes. I don't see any questions on the chat, but please feel free to raise your hand and unmute yourself or post them in the chat. And I see already the first hand up from Ronald Marsh.
Okay, thank you very much, Patricia, and thank you very much, Ivalda and Professor Anand, for the presentation. Just to check, can you hear me clearly?
I can hear you clearly.
Very good. Okay. Thank you, Professor Anand. I've got two questions. One for you. One, you said only a state level report has been processed. So I was wondering why, because so as I said, I'm Ronald, and I'm with the University of Toronto, originally from Sierra Leone, and we also have an SRS system going. So I wanted to know why only state level reports are generated, because in Sierra Leone we do both national as well as subnational district level reports. So I don't know whether it's because the sample size is just 0.6% of the population, and so you believe that you don't have enough adequate admission areas within the districts or regions. So I'd like to know. That is one. Two, you showed us a form, which is a short form, which you said you're using to collect data. So I'm wondering why are you guys not using the standard WHO questionnaires, whether it's 2016 questionnaire or 2022 questionnaires, because the probing of signs and symptoms and the quality of the narrative is very important for proper determination of cause of death. I am a physician coder as well. So, and besides, the standard forms designed by the WHO also works well with algorithms such as in silico VA, InterVA5, and all. So I'm wondering why you're using the short form, which can jeopardize the quality of the narrative and give us a biased cause of death data. Over.
Thank you, Ronald. The first one, we give national and state level estimates. We don't provide district level because the sample size is too small for generating district level estimates. So that is the reason no district level estimates are ever given. It is small for even smaller states in India, but for the larger states, we do generate state level estimates. So, and national is definitely released. So that's for the first one. The second one about the VA tool, unfortunately, this was the tool that was decided when we started in 1999, when I was not part of this. And now changing a tool will require a lot of advocacy. They are very hesitant to change the tool because, see, when you add something to an existing work, the people resist that as an incremental work, and that's a good thing for the other side. So you have to say, okay, it is not a very big amount of new work. The additional work is a small work, so you will only give a small tool. If you do a large tool, there's a definite likelihood that they would simply refuse to do this as an additional work. However, we are now moving into doing VS through the health system, we are definitely using the WHO VA tool. So there also we expect to face challenges from the health workers because they will see this as an additional work. But that's battle we are going to fight in the near future. Which tool to use? But ultimately, that's a tool that government has to decide. I'm from an academic organization. It's not my decision to make. I will have to go to them with, as you are rightly saying, that this is the length, this takes this much time, this is the quality, and then leave it to the government to take that call. Thank you.
Thank you very much for the question. I'm putting up the chat. I see there is a question from Will in here. Yes, also I think it's also for Professor Krishnan. So the question is, if the sample frame changes every 10 years, does the index population for active surveillance also change, or is that a static but additive? Thank you.
I think there are additional things. The unit stays the same, but they keep adding newer units to it.
Okay.
Sorry, I think I stand corrected. I think they select a new sample every 10 years, so it could keep changing.
Okay, thank you. I see there's another hand, but I also have here Daniel asking me for
I'm raising my hand in
yes.
person. Yes, I have probably a quick question for Ivalda, because I saw that you presented a paper of a survey that you implemented on top of the SRS, and we've been having discussions internally on trying to build a business an economic case for SRS. And one of the cases is that if you have a kind of a system that has already a population under surveillance and you are monitoring them, when you want to do a specific survey, you will save money basically because you will have all of that done already. So I don't know if you did this analysis as part of that survey, but if you didn't, how much you think that you saved in resources, not money only, but in resources by having an SRS when implementing these surveys?
Thank you, Daniel, for your question. For this specific paper that is shared, we did a pilot in one of the provinces of the country, and now we are going to do it in other 3 provinces. We didn't do the specific cost analysis because this was something new. This was the first time we were implementing a multiplex in Mozambique to assess for more than 16 pathogens. But we did a cost analysis for a potential fear survey, and we actually did this in 2018 or 19, if I'm not wrong, where we tried to convince the health sector to use SRS for our last HIV survey, but they were not comfortable at the moment. But now that the financial global situation changed, actually it was CDC and the health sector that came to us and asked if we could discuss and come up with a cost analysis and with the methodology for this. And it was successful. We definitely noticed that there is a lot of reduction, basically because when we went to implement a survey, you need all the cartography, and so this is the most costly phase of the survey. So we can cut that phase if we do have an SRS. So and this there are a lot of discussions right now, and potentially the next FIA survey, although there's no DHS anymore, the country needs to keep implementing HIV and other diseases survey. So we are discussing that maybe in 2 years we will be implementing an integrated survey in Mozambique based in our SRS in Mozambique. And we can definitely share the costs and how we are saving on that.
Yes, thank you. Because just to add, because like we did a similar analysis, not with SRS, but with CRBS and DHS. Like how much would you save if you have already a platform where you can draw your sample, or you have, and we realized that yeah, like the bulk of the cost goes at the beginning of the survey when you need to like do the first like enumeration. So yeah, thank you. Really looking forward to seeing some of those results.
Thank you, Daniel and Ivalda. I think I saw one a raised hand before, and we have like about 3 minutes, so maybe we can take that question and then close the session. If this was not the same question as Daniel had.
So Patricia, can I?
Yes.
This is Dr. Faiza from Pakistan. Thank you both the presenters. This was a lovely interaction again. Listening to you always gives us more insight, and as we are developing our proposals and thinking about implementing the SRS here in our countries. So thank you for this. My particular comment or question is from Professor Anand. I just wanted to ask whether, because you are implementing a shorter version of verbal autopsy, and you said that the human resource is already employed by the government of India, probably the Office of Registrar, I believe. So for this additional work, do you pay? Do you incentivize the healthcare workers for doing the verbal autopsy part, or it's their routine job now?
Okay, so as I said, the SRS part has 2 sets of workers. One is the community enumerators, the part-time enumerators. They are paid a part-time amount. They are not fully salaried people, and they don't do verbal autopsy. Their job is only to identify that. Verbal autopsy is done by the supervisors, who are a full-time employees of the government. So they don't get paid anything additional for the doing the verbal autopsy. However, the physicians who code in the panel that I hope, physicians get an incentive of about $2.50 per forms that they code.
Dr. Faiza, is that is your question answered?
Yes, thank you very much. Thank you.
Perfect. So with that, we're perfectly on time. Thank you very much to both our speakers for sharing these valuable lessons. As Dr. Faiza said, I think it really helps the countries as they are now moving into this early implementation. And thank you also to all participants for attending and for your engagement. And I wish you a very great December until we see each other next again in January. Bye, everyone.
Thank you. Bye-bye.
As always, we will be sharing the slides and the webinar and recording. Bye.
Okay. Bye.